Okay, so our final speaker for the afternoon, I'd like to welcome back Thomas Klupa back to the stage. He's going to talk today about laminopathy. Thank you.
Thank you very much. So now I have the pleasure to discuss with you the problem of LMNA mutation carriers identification and treatment. Lamins are the components of the nuclear lamina. They provide a framework for nuclear envelope and may also interact with chromatin. The lamin function includes its role in muscle and adipocyte differentiation in the physiological aging. The clinical profile produced by mutations in lamins is very heterogeneous, but let's concentrate on the diabetes-related phenotype. As lamin acts as an inhibitor of adipocyte differentiation, LMNA gene mutations result in redistribution of adipocyte tissue. Mutations of the LMNA gene have been shown to cause an autosomal dominant form of insulin resistance with familial partial lipodystrophy, frequently accompanied by diabetes. So this is our case, the patient ADK. So she presented with diabetes and with peripheral lipodystrophy with almost no fat at the glucose. But, so our first thought was that she must be an LMNA mutation carrier. But then we had second thoughts, and we realized that she did not look like most of LMNA mutation carriers would be expected to look. So this is a lady from Catherine's paper, and look at this typical face and neck fat accumulation. Our patient was completely free from this pattern of fat distribution. However, a few years ago, there was a patient described by a French group, and he looked somehow similar to our patient. However, again, if we went to the details, there were some similarities, but also some differences. So there were sunken cheeks, there were square jaws, thin lips, but there were no signs of musculoskeletal hypertrophy as reported in the previously described case. So they were not 100% sure whether this patient was LMNA mutation carrier, so we looked for other options. And we realized that some families with partial lipodystrophy and normal LMNA sequence were found to have germline mutations in PPAR gamma. So we had a dilemma: where should we go first? Which gene should we sequence first? PPAR gamma or lamin? To answer these questions, we had to analyze her clinical picture in the details. So our patient was diagnosed with PLD, with a profound loss of subcutaneous fat from the upper and lower limbs. However, as I've mentioned before, without neck or face fat accumulation. She was diagnosed with fatty liver disease, with coronary heart disease, with myocardial infarction at the age of 39, with combined hyperlipidemia, bilateral partial cataract, chronic kidney disease with low creatinine clearance. At the time of examination, she was at that time 53 years of age. She was on insulin therapy with a daily dose of 67 units, which was an equivalent of 1.3 units per day. This is like a double dose in comparison to type 1 diabetics, for whom the typical insulin dose is 0.5 through 0.7. So it was like a double dose in comparison to type 1 diabetics. However, the insulin dose was much lower than for cases described in the literature. In addition, her C-peptide level was relatively high. It was 6.5 milligrams per milliliter. The age of diagnosis was 55 years. In addition, she was receiving metformin, although its dose was reduced to 500 milligrams per day due to decreased GFR. On this treatment, the patient's HbA1c was 6.9. Insulin sensitivity of this patient was assessed by hyperinsulinemic euglycemic clamp technique, which proved insulin resistance as M value was 3.3 milligrams per kilo per minute. In spite of aggressive lipid-lowering therapy, which included 40 milligrams of atorvastatin, 267 milligrams of micronized fenofibrate, and 2 grams of omega-3 fatty acids, the patient did not reach the goals of lipid control for subjects with diabetes and history of myocardial infarction. Her total cholesterol level was 4.21, LDL cholesterol was 2.61, HDL was 0.74, and TG level was 1.89. So this is the summary of some of the clinical features of selected LMNA and PPAR gamma mutation carriers. So we would like to compare the clinical features summarized on this table with the clinical picture of our patients. So as far as lymph fat is concerned, it was absent in LMNA mutation carriers, absent or decreased in PPAR gamma. For fascial fat, however, it's usually present in LMNA, whereas it's absent or decreased in PPAR gamma. So this is the point for PPAR gamma. For gluteal fat, it's absent or decreased in both cases. Lipodystrophy onset, adolescence or early adulthood. But as far as diabetes onset, the age of diagnosis was more typical for LMNA than for PPAR gamma. And early coronary disease, it's present in almost 50% of cases of LMNA, and it's usually absent in PPAR gamma. So that was the point for LMNA. However, if you look at hepatic steatosis, it's variable in LMNA mutation carriers, and it's present in PPAR gamma. So we had sort of equilibrium of arguments for both LMNA and PPAR gamma. The search for PPAR gamma mutations was negative, but during the sequencing of LMNA gene, we found that the patient was heterozygous for the previously reported G2A substitution at the codon 482, which predicted the replacement of arginine into glutamine. She was also heterozygous for a polymorphism in intransinks of LMNA gene and the silent mutation at the codon 446. There were some new features of her phenotype in comparison to previously described phenotypes that I'm going to characterize right now. She was diagnosed with pulmonary fibrosis at the age of 48. She was suspected of sarcoidosis. However, this diagnosis was never confirmed. She presented with low BMI, while most of other described mutations, this particular mutation carriers, were overweight. This may mean that the phenotype resulting for LMNA arginine to glutamine mutation includes some patients with BMI at the lower edge of normal limit. We cannot exclude that the phenotype was modified by the presence of silent mutation at the codon 446 that was found to be associated with development of type 2 diabetes in recently performed meta-analysis. Pulmonary fibrosis was not earlier reported as a feature associated with any mutations in the examined gene. We should, however, take into account that the existence of this phenomenon with other typical laminopathy characteristics was just the coincidence. And our case confirms the recent description that the diminished renal function or even renal failure may be a part of the clinical picture related to this particular mutation. She presented, as I've said before, with relatively low insulin requirement. This is probably partially a result of high preserved beta cell output as measured with C-peptide level. Alternatively, elevated C-peptide level in this case could be a result of its decreased renal and possibly muscular metabolism. The alternative explanation for relatively low insulin requirement may be just moderately decreased insulin sensitivity. So in summary, a clinical picture related to LMNA arginine to glutamine mutation may be more diversified than it was previously considered and may include low BMI and pulmonary fibrosis. Thank you very much.
Thank you, Tomasz, for this excellent presentation. Has anyone from the floor got any questions or comments?
I've got one comment. What is quite interesting that you've presented the patient with the mutation which causes laminopathy, and you pointed that this lady has got a low requirement of the insulin, which is quite interesting because you also said that this lady was a carrier of a silent mutation, which was related with the development of type 2 of diabetes. So theoretically, what could be quite logic that she should have got the increased insulin necessity to control.
Well, as far as the silent mutation, so the odds ratio for the risk of type 2 diabetes is very low, and so I would not pay too much attention to the presence of the silent mutation. However, again, this case
underlined that it was related with the
yes, but again, the odds ratio is very low, so we cannot explain this phenomenon well.
Just interesting point.
Okay.
Thanks. Very interesting presentation.
Okay, if there are no further questions, I think we'll draw this session to a close. Thanks everybody for your attention and attendance.
Thank you.